Welcome. Here we focus on cardiomyopathies. The name suggests that this is to do with abnormal cardiac muscle and the consequences of this. First of all, the normal physiology of cardiac muscle is such that this muscle is limited to the heart, and this muscle makes up the middle layer within the heart wall called myocardium, and its function is to enable the heart to pump blood. So when there is abnormality associated with cardiac muscle, the function that would be affected is pumping ability of the heart. So there would be less of this ability and therefore decreased cardiac output. And another consequence is that the heart will be filled with blood that cannot be pumped, and that leads to other complications, as we will look at soon. So in a nutshell, any disease that affects myocardium, the middle layer containing cardiac muscle, leads to myocardial dysfunction and typically leads to congestive heart failure. Congestive meaning blood pools within the heart and makes the heart hold on to this blood and not able to pump this blood. And the tissue will be deprived of blood, that's depending on cardiac output, and also the heart itself becomes weaker, and one time or another it gives up its function of its ability to pump blood, ultimately leading to death. Okay, so you can organize the causes into two groups: primary and secondary. Primary is where the conditions that cause cardiomyopathies is solely to the cardiac muscle, not throughout the body. Okay, so their focus is cardiac muscle. Secondary is where yet another condition that may also involve the heart, or a condition indirectly affects cardiac muscle. Okay, so there are a long list of conditions in both groups. Here we have primary cardiomyopathies. Looking at the table, you see that there are genetic components, there are acquired components, and mixed is where you have both genetic and acquired components together. Okay, although the list of abnormalities is long, we will focus on a few examples. Here we will talk about hypertrophic, dilated, and restrictive cardiomyopathies. Okay. Then secondary causes, a number of them. So it's organized very nicely. Infiltrative is where the cells are abnormal because of in amyloidosis, for example, protein folding is abnormal. Okay, so the buildup of protein is causing the muscle fiber to be abnormal, and therefore is not able to participate in contraction. Storage disease is where glycogen storage is affected. Toxic is where a number of drugs are listed here. They affect many other structures as well as cardiac muscle. You are familiar with most of these drugs, and they can be carcinogenic, and they also affect the cardiac muscle. Inflammatory is where sarcoidosis is a good example that involves cardiac muscle as well. Endomyocardial is the inner lining of the myocardium. Okay, so that is where there may be inflammation, and so fibrosis is where the muscle tissue is replaced by fibers that would cause cardiac muscle dysfunction. Endocrine is where hormones, hyperthyroidism, or hypothyroidism, pheochromocytoma, acromegaly, diabetes. So these conditions could also involve the cardiac muscle indirectly. All right, neuromuscular conditions, Duchenne Becker dystrophy, where dystrophin is abnormal, so the damage is for the muscle fiber. Then neurofibromatosis, tuberous sclerosis. Again, sclerosis is where fibrous tissue replaces healthy muscle fibers. Autoimmune conditions, there are a long list of those. Lupus is one, rheumatoid arthritis, and so on. Okay, so you know that there are a number of possible causes for cardiomyopathy. So your goal is to make the connection. If you come across a patient with one of these conditions, you should be able to make the connection to say, well, this condition may affect the heart, and therefore you have to look for some abnormalities related to the pumping action of the heart. Good. With that, let's look at one specific condition here, a dilated or congestive cardiomyopathy. Okay, the name gives the definition. All right, the heart gets enlarged. When it gets enlarged, it's congested with blood. Right? Now, very simple detail, that is, you're talking about ventricular dilation specifically. Okay, ventricles are the ones that receive blood, and then they pump blood into the blood vessels. Okay, ventricular dilation is possible when there is more blood arriving here. Okay, increased in diastolic volume could stretch the wall slightly. All right, so this is normal, and you're looking at an abnormal situation. There is more blood arriving here in the ventricle, and the dilation is beyond normal. Okay, beyond normal. This happens to be the most common kind. The cause is mostly from unknown causes, but some conditions are related to genetic. Okay, about a fourth to a third of those that suffer is because of genetic reasons. Okay, here you're talking about Duchenne muscular dystrophy is one example. Hemochromatosis, that is the accumulation of iron causing damage to muscle tissue. Myocarditis is inflammation, drugs, cocaine, chemotherapy. Postpartum state. Postpartum state is where a woman, right after giving birth, would have enlarged heart. Okay, it takes time for it to regress, return to its normal size, but that's a temporary situation where you may have dilated cardiomyopathy. Thiamine deficiency, that is vitamin B deficiency, typically alcoholics develop this condition, and the most common cause is myocardial ischemia. Most common cause, myocardial ischemia and myocardial infarction related to that. And most familiar cause is myocardial ischemia. We have, unfortunately, a poorly designed blood supply to the heart. Coronary arteries, as you may have learned, uh, supply the heart during diastole. Their supply is limited in terms of when the heart gets enlarged, the capillaries do not add extra capillaries. So this limitation is the cause of myocardial ischemia, myocardial infarction. And now what happens is you have limited number of muscle fibers to use. Some have been lost due to ischemic condition. So limited number of muscle fibers would affect the function of the myocardium. All right, so basically decreased contractility, that is contractile function of the muscle is not enough, less than normal, which invariably affects ejection fraction, stroke volume. See here, ejection fraction is less than 40% when the normal ejection fraction is supposed to be about 55%. Impaired systolic function. Okay, systole is where you pump blood, and obviously it's impaired. Increased intracardiac volume. This is another obvious condition, right? So they're all interconnected. When the muscle cannot contract, ejection fraction is reduced, and then increased volume within the ventricle. So ventricle dilates because of the increased volume, it stretches the wall. Okay, then systolic heart failure. Systolic heart failure is where you are not able to pump blood. Pumping ability is reduced, and that is what you call as systolic heart failure. Good. So clinical manifestations, enlargement of the heart is one thing. ECG would have abnormalities, basically showing poor contractility. There may be bundle branch blocks because of the stretching. You have to imagine how it would interfere with the conduction of action potentials. So that's what you call as atrial and ventricular arrhythmias. Hollow cystic murmur, that is between S1 and S2. These are heart sounds, S1 and S2. You would hear this high pitch murmur, the entire length between S1 and S2. So that is hollow cystic murmur. S3 murmur is heard during early diastole, blood rushing into ventricles during diastole. All right, because there is so much blood within the heart, you hear this sound, S3 sound. It's an abnormal sound during diastole. Okay, symptoms of forward failure. Forward failure is blood should be released from the ventricle into the artery, right? That is not happening. Now there is less blood being received by the body, so fatigue, hypotension, oliguria, all of those are associated with poor blood supply by the heart. Okay, so that's what you refer to as forward failure. Backward failure is basically building of blood within the heart. Okay, blood remaining in the heart. What are the consequences of that is what we want to look at. So because you're pooling blood in the heart, there is increased filling pressure and ventricular failure. Because you have more blood in the chamber, there is more pressure, and the wall is stretching, and the expansion of the chamber, ventricular failure. left ventricular dilation may cause mitral regurgitation. Okay, so blood moving back up into the left atrium. All of these could lead to blood in the left atrium ultimately may go where? Into the lungs, right? So now, increased volume within the lung could interfere with the gas exchange function of the lungs. Orthopnea is again a difficulty breathing while working out, paroxysmal, that is on and off, nocturnal dyspnea, dyspnea is difficulty breathing, and then pulmonary edema because of the pooling of blood, that is because of the backward flow of blood because of the increased volume within the ventricle. All right, so those are some clinical manifestations. And so how would you deal with these patients is the next thing, because you are aware that the heart is not able to pump, and the drugs that you use would be causing these functions to be exaggerated more. You need to be aware of this. Okay, avoid myocardial depression. Okay, further depression of the function is what we're talking about here. Maintain normovolemia, prevent increases in afterload. Okay, so prognosis with these patients is 5-year survival rate in 25 to 40%, mainly from congestive heart failure, embolism, sudden death from arrhythmia. Okay, so you can see how this wall is much thinner and then now expanded, unreasonable. Okay, huge here. Got it? Good. Restrictive cardiomyopathy is the opposite of what we just talked about. Here, it's a genetic condition. Okay, amyloidosis is one of the causes of restrictive cardiomyopathy. Infiltrative is where you can think about sarcoidosis. That is where you have the buildup of immune cells. Storage disease is where iron deposition. Endomyocardial fibrosis is where you have accumulation of eosinophils due to inflammation in the area. Fibroelastosis is mostly in children, right? So fibroelastic fibers now replaced by fibrous structures. So the elasticity of the muscle, the stretching ability of the muscle is lost there. And then other cause could be radiation that leads to buildup of reactive oxygen species, which, as you know, causes inflammation. Okay, so these are the causes of restrictive cardiomyopathy. Now, looking at what exactly happens here, it is infiltration of fibrous tissue into myocardium. You see, myocardial muscle fibers are replaced by another type of tissue that is going to be of no use. Okay, and it replaces the healthy muscle fibers as well as in the endocardium. So that makes the wall become stiff and non-compliant. Non-compliant meaning when the blood is in the chamber, it has to stretch to accommodate. That is not going to be possible. So there is increased filling pressure during diastole because of the stiffness. Because it's not able to expand, the pressure here is always going to be on the higher end. When there is higher pressure in the ventricle, guess what happens? There is less filling, right? There's blood flows from higher to lower pressure. Okay, I mean blood, air, water, anything. Well, it's a natural phenomenon to move from higher to lower pressure. But here you have a condition where the pressure is high. Okay, blood may not reach the ventricle as usual because of this difference in pressure. Okay, decreased ventricular filling, decreased end diastolic volume. So decreased ventricular preload, decreased stroke volume. So it's all related to one factor, that is stiffness of the wall, because of the lack of normal healthy muscle fibers, but replaced by fibrous tissue. Okay, good. So one thing leads to another. Blood doesn't arrive into the ventricle, so reduced end diastolic volume, reduced stroke volume. That's it. Okay. Atria become dilated as a compensatory response to volume overload. So blood is in the atria, not reaching the ventricles. So what happens to the situation in the atria? Here you have to think about the enlargement of the atria. Blood has pooled here, and now from the atria, blood would back up into where? Into the lung. From the lung, it would back up into the right side of the heart, you see. So over time, because blood is not reaching the left ventricle, it backs up into the lung, and from there it backs up into the right ventricle and then into the right atrium. Okay, atria become dilated, left and right-sided heart failure. Okay, diastolic heart failure is how you refer to this. Diastolic meaning there is less blood than normal, so there is very little blood to pump. Okay, little blood to pump because you're not able to fill with blood. So systolic is where you cannot pump blood even though you have blood in the chamber. Diastolic heart failure is where you have very little blood, so you are pumping less blood out. All right, diagnosed using ECG changes. All right, restrictive cardiomyopathy. Here, the clinical manifestations is what we want to talk about. More or less similar manifestations. Because remember, it's the left side of the heart, right side of the heart, as well as the lungs, all being affected. Dyspnea, difficulty breathing, fatigue, cardiomegaly, that is enlargement of the heart. Now, it's not the ventricles that are enlarged, but still you're talking about the right side being enlarged, the atria being enlarged, atrioventricular valve regurgitation. So valves are now pushing blood backwards because of the volume overload. Jugular venous distension. This is where the jugular vein, this is basically now backing of blood in the veins. So the veins that bring blood into the right atrium and right ventricle is through the superior inferior vena cava, and now blood is backed into the vena cava, so blood backs into the major veins, and that is where you're looking at jugular vein as one of the closest veins to superior vena cava, and that would be dilated, okay, distended. Pulmonary hypertension, and due to that is where you would hear sounds during breathing rails. Pulmonary hypertension because of the volume here being greater than normal. Okay, so basically here again you would look at minimizing myocardial depression. Now, next one we want to discuss is the hypertrophic condition of the heart. Hypertrophic heart is where you're talking about asymmetry. What is going on here? Hypertrophy means the muscle fibers number has expanded. Okay, so expanded number we probably think is good because, it can pump better, it can pump more blood, and so the person will be able to do, more than normal things, etc. No, here it's the opposite. Well, before we look at how it's not helpful, we will also look at some basic details. First, it's a genetic condition. It's an autosomal dominant condition where calcium ion channels are in greater numbers than normal, okay, leading to myocardial hypertrophy. Okay, so calcium ion channels being more than normal, they bring more calcium into the muscle fiber, isn't it? Now, the age group that would be affected typically is the middle to older age group, 50 to 70 years of age, men commonly than women. So the way it occurs is the enlargement or the addition of muscle fibers in one part of the heart or another. Okay, it could happen anywhere, but most commonly it is in the interventricular septum. Most commonly here in the left ventricle, closer to the aortic valve. Well, this is just a possibility that the position is close to aortic valve that we are looking at, right? It could be anywhere else, but what if it's close to the aortic valve? The way it's shown here would interfere with blood flow from the left atrium into the aorta. Okay, there is this narrow opening now because of the space it has occupied here, right? So blood will not leave in normal amounts when blood is pumping. Blood is pumped by the heart. So obstruction of blood flow below aortic valve is a common situation. Coronary artery disease could be the consequence of this because you're releasing less blood than normal. Okay, valvular dysfunction. Yeah, what happens is it then pushes the mitral valve into this upward position. So it's kind of one condition leading to another condition. All right. So valvular dysfunction, ventricular remodeling, and hypertension. So those are some causes of this hypertrophy. Thickening restricts filling. Okay, blood backs up in the vessels, and that is how you would have high blood pressure. Okay, that leads to abnormal heart sounds, murmur, conduction disturbances, and sudden death. And this is one of the most common causes of sudden death in young adult population and in children. Okay, due to this genetic situation where the heart wall is asymmetrically thicker than normal. Okay, so let's look at this slide here. Because of this asymmetry, because of the hypertrophy, compliance is not there. Okay, compliance is the ability to stretch, and it's this elastic nature. All right, increased left ventricular end diastolic pressure would be greater than normal, just like in the restrictive cardiomyopathy that we talked about, and therefore less filling. Okay, end diastolic volume would be reduced depending upon the location. Low to normal end diastolic volume requires a greater contribution of volume from atrial contraction. Okay, so atria have to contract. Before it's all passive filling, but now atrial contraction is what would push blood to the ventricle, and then that leads to congestive heart failure. Increased contractility exacerbates the obstruction by increased septal wall contraction and decreased cardiac output. So really, although the contractility is increased, it exacerbates the obstruction. So when the muscles contract here, the aortic wall closure would be worse than before contraction. So that is where you are not able to pump enough blood, decreased cardiac output. Decreased preload changes left ventricular geometry, okay? Because you're not able to bring enough blood into the ventricle, then that would also affect the anterior leaflet of the mitral valve into closer proximity of the hypertrophic septum. So that would obstruct the outflow as well. So let's go back here and look at the mitral valve. So here is our aortic valve, here is our mitral valve, and there is less filling. So these leaflets here move in this direction, okay? So they are interfering with the outflow of blood. Got it? So that's called Venturi effect. Look at the space here, it's very narrow, and the leaflets have assumed a new position, blocking the outflow, and here this growth is also interfering with the outflow. All right, obstructs outflow, Venturi effect. Crescendo, decrescendo murmur, that is, loud sound when blood is released, and then the sound softens later, kind of murmur is what you hear typically in this condition. Here is a beautiful summary of the three kinds of myopathies that we went over. This is a beautiful normal ventricular wall and dilated here, right? Look at the size and the thinness here. Then you're talking about hypertrophic, where the thickness is uneven. Notice here, very little room for filling, and the mitral valve position is not the same. Then there is less room for blood to move into the aorta. Then this is where restrictive cardiomyopathy. Here, the wall is stiff. Okay, when the wall is stiff, what happens is it doesn't expand, so little room here the pressure is too high for it to receive blood, correct? So that is all about cardiomyopathy, and thank you.